Hi, everybody. My name is Dana Howard, and I am a member of the Center for Bioethics and the Philosophy Department at The Ohio State University. Welcome to our first Conversations about Research Ethics Care panel of 2026. The Center for Ethics and Human Values hosts these monthly panels to really talk about and support Ohio State's shared values in the domain of research by building a community around discussions related to research integrity and emerging topics, as is this one today. The CARE program is presented with support from the OSUMC Center for Bioethics, as well as the Clinical and Translational Science Institute. And we're so happy to have all of you here today. So today's panel is going to be about something that I'm just like really interested, like it's new to me. So I'm really excited to have Jasmine and Mikaela here. We're going to be talking about how intimacy and vulnerability in research relationships can give rise to unique and often overlooked forms of harm in the research context. And so we're delighted to have two panelists, one from OSU and one from Western University. So Jasmine Gunkel is our external expert panelist. Jasmine is an assistant professor of philosophy at Western University in Ontario, specializing in the philosophy of intimacy. Jasmine has written about how considerations of intimacy may be relevant to research as well as clinical practice. And prior to her position at Western Ontario, um, uh, Dr. Gunkel completed a postdoctoral fellowship at the National Institutes of Health in the Department of Bioethics there. Welcome, Jasmine. So Jasmine is going to start us off with like a sort of 20-minute or so presentation about some of the work and scholarship that you've been thinking about. And then we're going to have a presentation and introductory remarks by Mikaela Smith, who is a research scientist in the epidemiology program in the College of Public Health at The Ohio State University. Mikaela is a research scientist with the Ohio Policy Evaluation Network. And within OPEN, Dr. Smith researches the utilization of abortion and contraception care within Ohio's reproductive policy landscape. And so what we're hoping to do after the initial presentations is I came up with some preset questions, so we'll discuss those. And then participants in the audience, if you look at the bottom of your screen, there is like a Q&A icon. Feel free throughout the discussion to start asking questions, and we'll have plenty of time to ask your questions the last 30 or so minutes of the conversation. So those are the introductory remarks. Jasmine and Mikaela, thank you so much for joining us on a very snowy day. We appreciate you being here.
Thank you. So shall I get started with sharing this? All right, I hope you're all able to see this. Great. Okay, so I'm going to be talking to you today about this overlooked risk in research, which I think is the risk of intimate violation, but also a little more broadly, and we'll get into that too, thinking about other sorts of intimate harms that can exist in research, even if it's perhaps not rising to the level of an intimate violation. And I'll say some things as we go on that I hope will make this distinction a little bit clearer. So, some organizing questions for my section of this panel. So, first off, what exactly are intimate violations? And why are they so morally significant, right? When we hear this phrase, I think intuitively we have this sense that when something is an intimate violation, that's a particularly serious sort of issue for our rights and our well-being. But why actually is that? So I think we can actually say a little bit more about that and go beyond some of these intuitions we have that it's wrong and get a little more specific in ways that I think are going to be helpful for then guiding us in making some of these decisions as IRB members, setting regulation, as researchers, as care providers. And so, intimate violations, what exactly is the relationship to the minimal risk standard? And I think this is particularly important because um, with the minimal risk standard, sometimes if we're judging that something is falling below this standard of this minimal risk, then uh, research regulations are relaxed in some ways, right? So you don't have to necessarily get consent to do research in all cases if the risk is judged to be below this threshold. And so I think that's especially important here, because then, if you don't need consent, that's particularly worrying in the case when things are indeed intimate. And so we'll talk especially about those cases, but also, of course, these risks can be relevant even when there is consent and even when risks are above this threshold. So we'll talk a little bit about that too. So how is it that we identify and anticipate these risks? Right? So this is another one where I think we have some intuitive sense of what procedures might be likely to be intimate, and we do often already have some guardrails in place when that's so. Think, for instance, to how practices have changed around pelvic exams under anesthesia. But I think having a broader conception of what these intimate risks and harms really are allows us to see some cases where it's not so obvious to us that they might be intimate. And so I think actually thinking about how to identify them is going to be really helpful for those sorts of cases. And so finally, then how should we be minimizing these intimacy-related harms in research, whether that's the harm of intimate violation, but other kinds of harms too? Okay, so to start off, I'm going to give you a couple of cases that I like to start off with that I think are helpful for wrapping your head around why it is really helpful to be thinking about intimacy in particular and in more detail and more depth. Rather than just using our sort of intuitive notions of what intimacy is, um, both in the research context and otherwise. So in this first set of cases, it's a pair of cases. So imagine that you're hosting a dinner party, and in the first version of this case, there's some uninvited guest that comes, a friend of a friend that comes to your dinner party, and while you're in the kitchen, still getting ready, making sure things are set to go on the table, this guest starts looking through your bookshelf, your bedroom drawers, and in one version of the case, the first version, they pick up your bird watching field notes that you've left on your side table of next to your bed, and they leaf through that. And there's something creepy about this. But compare this to the second version of the case, where instead of on your bedside table, it being your bird watching field notes, it's your dream journal, right? And so instead, they're really reading about what's going on in your mind at night, sort of the things your unconscious is conjuring up, and maybe your feelings about that too. So I think intuitively, there's something more violating about this second case, right? It strikes us as more intimate. And I think that's an important part of why it's worse. And so the second version, the second pair of cases that I think is helpful for getting our intuitions going here, is so imagine you're walking on a street, and in the first version of this case, a stranger grabs your forearm. It's creepy, it's surprising, it seems like a violation of your bodily autonomy. But in the second version of this case, instead of grabbing your forearm, they grab your butt, right? So I think you still have this violation of bodily autonomy, but it strikes us that there's something worse about this second one, right? It's an instance of sexual assault as well. And so I think what's helpful is having an account of intimacy that can help us make sense of what's running through both of these cases, and that also can extend further and help us to identify places where there's intimacy that are less obvious to us. So, and that can give us a story about how it is that this makes us vulnerable in a particular way. So then we can think about how to best guard against that vulnerability and mitigate it. So in previous work, I develop an account of intimacy, and I argue that intimacy is that which reveals our intimate zones. And so it doesn't sound that exciting when you just say that, but I give some conditions on what these intimate zones are that I think are then helpful and allow us to see them in the wider world and act accordingly. And so intimate zones, I say, there's two conditions for something to be an intimate zone of a person. Um, and the first is what I call hiddenness, and the second is important. So I'm using these in particular technical ways, though I think you can grasp approximately what they're like just from how they sound. So hiddenness has to do with our disposition to keep something hidden from the general view, right? The sense that there's something psychologically uncomfortable about the act of exposure. And I think exactly how it's psychologically uncomfortable is important. I'll say a little bit more about that um, shortly, though we don't have to get too into the weeds here for the purposes of this talk. And so importance has to do with it being a part of how we see ourselves. Right? So it's somehow important to our self-conception. And importantly here, I don't think this is just has to do with, who we believe we are, or what we believe is revealing who we are in some meaningful way, but also what we fear might worry, what we fear or worry might reveal who we are. And I think that's really important because I think those sorts of cognitive states too can also make us vulnerable in the same way that our beliefs can. And together, hiddenness and importance make us psychologically vulnerable in this particular way that intimacy does. It's characteristic of intimacy. And so some important pieces here that I think can give us a better sense of what these conditions are supposed to be. So I think importantly, intimate zones are individual in some way. So they are related to our own psychology because I think that's necessary for intimacy to play the role in our lives and to make us vulnerable in the way it does. Um, but for each of us, these intimate zones can change over time, right? So they're not static. So I think this is a helpful case to think about, what I call miscarriage awareness activist. So you can imagine that someone has a miscarriage, and at first when this happens, uh, because there's societal stigma around this, sometimes they feel a sense of shame. They don't want to talk about it. They worry that it was something they did. They feel very self-conscious about it. But over time, they realize that that's a bogus narrative, and that they shouldn't feel that way about that. They want to be comfortable talking about their experience, realizing this happens to a ton of people, and that it's a good thing to talk about. And so over time, they do become comfortable talking about this. And so I think that the fact that they had a miscarriage happen to them could be a very intimate fact about them at one point in time, but could slowly become more public and less vulnerable for them as they become more comfortable sharing this widely. And so importantly, I think social stigma and cultural influences do influence what our intimate features are. But they're not determinate. So I think ultimately it is our own psychology, because that's what's necessary to sort of play the psychological role. But I don't think that means we should despair when thinking about how to regulate this, because we can often look to some kinds of cultural patterns that can help us to make best guesses about what is likely to be particularly intimate for research subjects. And I think importantly here too, for thinking about intimacy in the context of research, is that even seemingly minor bodily features can take on outsized roles in our self-conception, and often that's how stigma can work. It can make us especially self-conscious of a feature, such that we come to believe it's a really big, important part of who we are. Okay, so intimate violations. I think an intimate violation is a non-consensual and insufficiently justified intrusion on an intimate zone. So, of course, these two terms here are doing a lot of work. So, Non-consensual, I think it's a little more intuitive what that is for the most part. Um, but insufficiently justified is doing a lot of work here too. So I'll say a little bit more about what it means to be insufficiently justified in the case of research a little bit later. But for now, some examples. So I think obviously reading someone's diary with their consent is not an intimate violation, right? It would be without their consent, but consent there is doing the work. Um, and also importantly, I think wiping an unconscious patient is not an intimate violation because it is justified uh, by the patient's own good, right? So I think that could be very intimately uncomfortable, right? There might be some intimate harms associated with that for the patient, but that's different and distinct from being an intimate violation because it is really essential to their good.
Jasmine, you are muted.
Uh-huh. Thank you.
Thank you.
Uh, as I was saying to myself a moment ago, intimacy has the potential to really deeply psychologically affect us. So I think in particular, we have to be worried about this risk for intimacy to inspire feelings of shame, um, because it has to do with these hidden and important parts of ourselves. And um, shame is distinct from emotions like guilt because it's really about the self in some way, right? So you might feel guilty about something you did. You're like, oh, I shouldn't have said that thing. That wasn't a very nice thing to do. What was I thinking? But when it moves into shame, instead the thought goes something like, oh my gosh, shouldn't have said that thing. What's wrong with me? Um, am I just not a kind enough person? I'm not this or that. And so shame has this important connection to the self, just like the importance condition does too. And so I think when you get uh, importance plus hiddenness together, we're liable to feel shame, and the shame that we do feel about these features tends to be particularly affecting, because then then when we do change in response to shame about our intimate features, it's not just about it's not that we're just changing in incidental ways, but often in ways that connect really deeply to who we are as people, because intimacy has to do with who we are as persons and our self-conception. But the details of that aren't terribly important for now. But I think this sort of risk of shame is in particular important to keep in mind as we're thinking about these harms in research. Uh, and so ultimately, also, I think uh, when intimacy goes wrong, right, we can have this tendency to abandon really essential pursuits, retreat from loved ones. So there's all kinds of other relational harms and autonomy-related harms that we should worry about here too. And so, in general, I think intimacy is less straightforward. Intimate harms are less straightforward than psychological harm, other kinds of psychological harms and physical harms. And so it's often overlooked, both in research and in philosophy generally. But I think these are really weighty risks. And certainly when the intimate risks and intimate harms are severe enough, can definitely make a study more than minimal risk. Um, and so finally, I said I would say a little bit about not only intimate violation in research, but other sorts of intimacy-related harms and the obligations that they give rise to. So I think as researchers, as members of IRBs, our duties around intimacy are extending beyond just avoiding intimate violations, right? So intimacy demands more from us. And even when intimacy is justified and is consensual, it can still make patients and research participants really vulnerable. And I think we have a duty to be responsive to that and to engage with sensitivity. And so there's interesting, difficult questions about what exactly sensitivity requires. I think one thing that is helpful to think about is thinking about how we can do something I call scaffolding against shame in patients and participants. So to protect them from those kinds of harms. Some things that are common practice too, like for instance, getting consent repeatedly as we're going through certain kinds of processes and procedures too. And so I think we should, in general, be thinking really carefully and thoughtfully about how it is that we can minimize intimacy related risks to participants. Okay, so I'm going to talk a little bit now, just briefly, about this particular case that I think is helpful for illustrating when thinking about intimacy can be helpful for us. So this was a proposed study some years back to help improve burn care. So the study was going to be on patients who came into the emergency room with quite severe burns. So
So we have Jasmine has lost connection for a second. So let's hold up. Apologies for the technical difficulties.
on burn outcomes.
So
And so,
Jasmine, just can you repeat what the start with the case? Just we lost you for a second. So
oh,
just 20 to 60% of the burn victims is where we were. Thank you.
okay, thank you. Sorry, I just got the internet connection unstable flash. So we're we're still having some snow and storm here. So hopefully this internet sticks around for the rest of this for me. But so in these cases, these patients are often coming in unconscious or in tremendous amounts of pain, such that it is very difficult to put them through any kind of consent process. And also, we should have ethical qualms about doing some kind of process like that with them in general at that moment in time. And so, the goal of this study was to think about the role of gut microbiome uh, and how that affected healing for people who were in who had these severe burns. And so the PI was asking for a waiver of consent for one perianal swab that would happen when these patients first came in to the emergency room to sort of get an idea of what their microbiome was like really on the moment of entrance, because that can change quickly in the hospital. And then, and importantly, it was just outside around the perianal area. And the PI noted that it was similar to similar touch to what would have happened, for instance, in cleaning the patient. And then for subsequent swabs, they would get consent, perhaps from surrogates of the family member. And so the IRBs then had to wrestle with this question: should this be allowed? Should you be able to get a waiver of consent for this first perianal swab? And so I think in general, right, this common intuition that people have, don't touch people's private parts without consent, right, is generally a widely accepted moral rule for good reason. But of course, this principle admits some exceptions, right? Even so. So when it is that this person can't consent themselves, right? For instance, it's an infant or someone who is unconscious. We allow that sometimes this touch can be okay, but generally, the agreed upon exception is when it's in some way for their own good. And so I think that is important as we're thinking about, right, intimate violations are non-consensual and insufficiently justified. So I think that that has to be the sort of exception has to be something like when it's for the person's own good, in a very strong way, right? So exactly how much for their good does it have to be? um, I think can be difficult questions, but something like that I think is going to be the right rule. Um, and so finally, three sort of considerations here. Um, like the perianal area, what's so intimate about that, right? It has this sort of close relationship to our private parts. And I think also interestingly, and this is a place that thinking about intimacy, I think a little not a little more not just going off our intuitions, but sort of having this account and thinking through it a little more carefully allows us to ask questions like, is the GI tract intimate? We don't have that same intuitive sense that it is, but I do think at both the macro and the micro level, it is often intimate. So that it's often associated with certain sorts of smells and indicators of health that people feel quite self-conscious about. Um, they sort of, I think, do worry sometimes it could reveal who they are, right? To have something really wrong with their health or to be unusually stinky or something in these ways. These are the sorts of, I think, bodily features that, uh, for some reason, for us humans, can take on these sort of outsized roles in our self-conception. And right, not that we necessarily believe that they reveal who we are, but also that we could fear or worry that they reveal who they are. And so I think that does make it such that we can be subject to sort of disproportionate harms, these intimate harms in particular, and things like shame. Um, and so importantly, right, that we can touch a person to clean them for some short period of time doesn't entail that we have extended permission to touch them when it's not for their own good. So I think it's really important to draw this distinction and not let in any sorts of touch of places that normally would only be permissible to touch, either with consent or when it is indeed for this person's own good and they're unable to consent. Um, so in general, this will be the last bit. How is it that we anticipate intimate risks? Um, so I think we can ask questions about hidden importance and when is it likely, uh, as we're sitting on an IRB, that there are going to be intimate risks involved. So I think that's a helpful lens. But of course, we can't perfectly predict what is going to be intimate for other people, I think. And so an individual is generally the best judge of their intimate zones. And I think that is at least part of the role that consent plays, right? So that's part of why consent is so important, is because individuals are particularly good at knowing the risks for them in particular around their own intimate zones and knowing what their own intimate zones are. Um, so surrogates, of course, and good surrogates are the next best thing. But I do think we actually, and interestingly, have particular reason to worry that, in particular, surrogates will struggle to know patients' intimate susceptibilities compared to, of course, there's issues with surrogates being able to predict uh, a patient's preferences in general, but I think especially around these intimate preferences, um, predictions are liable to go wrong because depending especially on who the surrogate is, right, they might not talk about these sorts of intimate issues with their surrogates. Maybe it's more likely in the case of a spouse, for instance, might have a better sense of this, but especially when the surrogate in question is, someone's parent or child, adult child, and this I think is something we really have to worry about here. And then finally, I think knowing the relevant social and cultural norms around intimacy for whatever sort of patient or research participant population you're working with is a good way to know when it might be appropriate to make sure consent is asked for, it's careful, there's sensitivity involved, that consent is an ongoing sort of process. I think that will be particularly vital, especially in cases where getting consent from a particular person is not possible. Then I think knowing these norms is especially important. Okay, I think that's it for me for now. Thank you.
Thank you so much, Jasmine. we already have questions coming up in the Q&A. We're going to definitely get to them. There's some great questions. But before we do that, Mikaela, why don't you introduce your own thinking about this? I mean, one thing I love about sort of the I want to hear from both of you is, some of the ways in which intimacy does feel very physical, but then as Jasmine, as you were explaining, like it's also about our data and sort of what we say and what we write. And so it's not always about the physical intimacy. And so I would love to hear from Mikaela some of the things that you've been thinking about and how you sort of engage in questions of vulnerability and intimacy in your own research.
Yeah, thank you. It's really great to be on this panel today. Jasmine, I really enjoyed reading some of your work in preparation for it. And I found that the language you give around intimacy, um, like provides this kind of underpinning for why abortion can be so complicated, interesting as a research topic, evocative for a lot of people. So yeah, I'll jump in here. So most of my research, like Dana mentioned in the intro, is on abortion access in Ohio and the Midwest. I do some cross-state comparison research. I also look at public opinion on abortion. I have some work on contraception, but just kind of a big, broad overview. My background's in sociology, so my PhD was in sociology. And now I focus a lot on equity and healthcare access. And so while I focus on abortion and contraception more so in my actual day-to-day research, I do ground my work in reproductive justice and intersectionality frameworks, just to give kind of a sense of where I'm coming from. Um, so because abortion is a topic that is complicated, there is some misinformation out there. I did want to start with some level setting about abortion in Ohio. I see there's a lot of people in the audience, but I don't know exactly who or what your background is on abortion knowledge. So I'll start by saying abortion is legal in Ohio up to 22 weeks gestation. Abortions are performed either procedurally or also known as surgically, or via medication to end a pregnancy. Medication abortion is legal up to 12 weeks in Ohio. And patients can get medication abortion pills either in person at a medical facility or in the mail via telehealth. All of that is legal in Ohio. Abortion is safe. It's safer than carrying a pregnancy to term. Dr. Gunkel writes in some of her work about gestation, how abortion involves less intimacy with medical professionals than carrying a pregnancy to term. So I think that's something interesting to think about. Abortion is also common. 1 in 4 pregnancy-capable people in the US will have an abortion in their lifetime. And in Ohio, there are about 22,000 abortions performed each year. Importantly, abortion laws do differ by state. And, the Dobbs decision that happened in 2022 really shifted the abortion policy landscape in the US. But it is legal to cross state lines for abortion care. And then the last thing I'll say is just because abortion is legal, it doesn't mean that it's always accessible or equally accessible by all people who are seeking this care. And that's where Open focuses a lot of its work. So I'm happy to talk more about questions folks might have about abortion access or contraception access in Ohio, if that comes up. But yeah, turning a little bit to intimacy and abortion research. So I'm going to start by talking about the practical parts of intimacy and data collection, talking a little bit about quantitative versus qualitative approaches. Next, I'm going to talk about abortion research specifically, why abortion is a unique case for both conducting research and then also discussions of intimacy. And then I'll talk a little bit, just a little bit about recent concerns around data security, patient privacy, concerns for intimate violations and criminalization as abortion has become more restricted in different states. And of course, technologies are continuing to advance. So first, yeah, talking about quantitative versus qualitative work. So before my undergraduate was in math, and so I came into my PhD with a quant background, but I did take qualitative training. And so I have a little bit, I've dabbled in both, but I'm really more of a quantitative sociologist now. And in reflecting on that today, I think there's some level of intimacy in quantitative versus qualitative research that has informed some of the career trajectory just for myself. So within the work that I do now, when I say quantitative, there's a couple different places that we can get our statistics from. I think what I'll talk most about today is medical charts at abortion clinics is where we get patient level information. We also get aggregate information from clinics, so like the total number of abortions that they provide each month, say. state health departments publish annual reports. Ohio is one of them. And the CDC often gathers information from the state health departments, publishes that annually. So these are all aggregate level, again, how many abortions in a year, were they medication or procedural, those kinds of things. There's other research organizations. The Gubacher Institute is well known for having solid abortion statistics. And even within this list of quantitative data, there's a little bit of a hierarchy of intimacy. Reading someone's medical chart feels a lot more intimate than just going on a website and CDC website and downloading a spreadsheet. And yet in reading the medical record, I'm still not engaging directly with a patient. And so in preparing for this today, I was talking with my colleague, Sarah Crow, Opens communications specialist. And I was kind of talking about this difference. What is the experience difference from my end on accessing medical chart versus downloading data versus talking to a patient? And she described it as a secondhand intimacy. And I think that captures it really well. So when I see data from someone's medical chart, I am looking at it and thinking of them as this whole complex person, but the data in front of me is inherently not their whole person. It's information they shared with an abortion clinic at the time of their care for their care purposes, right? It wasn't even collected with research in mind. And so I'm now several steps removed. There's them to the provider to the medical record, and then the medical record to what I might see in the data. And so again, there's this shift of intimacy, right? Intimacy between the person and the provider, and then the provider and myself as a researcher. So given that I'm not engaging directly with patients, we do think a lot about how to protect the patient data, the patient intimacy when using the secondary data. First, it's important that we don't look at, a medical chart and say, oh, this is clearly this patient's experience, unless sometimes there's notes written out, but just by looking at the patient's demographics, when they came in for their abortion, how long they waited. As scientists, we try and draw kind of patterns, conclusions by looking across several records, but we can't really make any assumptions about their actual experience. So it's important, not to make those assumptions. Second, we don't develop relationships with the patients, but we do spend a lot of time developing relationships or intimacies with the staff at the clinic. They're the gatekeepers to the data and to the patients. And we spend a lot of time making sure that we build the rapport and relationships with these providers so that we have this foundation of intimacy from which we can navigate if there are complications. If we were to do something that they didn't feel was comfortable, that they would be able to kind of assert those boundaries towards us. And then third, of course, there's the kind of formal agreements. We have everyone on our team says a privacy agreement. Everyone has to do city training, IRB training. We do a lot of vetting in that way of like who are we actually sending to the clinics to collect this data, and will they be doing that sort of reading it in a non-judgmental way, taking a holistic kind of view of the patient. But that said, the patient whose chart we are reading doesn't know us, right? I can trust myself to look at it not judgmentally, respectfully, and all of these things that I value. And yet we haven't built that trust with them. And it does feel a little bit like an intimate violation. So I spoke with my colleague Hillary Gyrus, who's a research associate at University of Cincinnati, also with Open. And she was involved in the actual data collection for a lot of our chart review. And so I want to share a quote she sent back. She said, "This is a bit of an intimate thing, documentation of conversations with and by healthcare providers. Of course, we looked at so many records, we have no idea who any of these people were, and we have no way to remember their names. But to the average patient, would they feel that their trust of providers was damaged in any way by letting others access these intimate medical histories?" And I think it's complicated. We can definitely talk about it. It was IRB approved. It's very normative in public health to do medical chart review as a way of getting the data, but it does raise these questions. So then to talk a little bit about qualitative work, in qualitative work, so we're talking about interviews, focus groups, ethnographies, things like this. You do have to develop some sort of rapport or trust or intimacy with the participants. Hillary and myself and a couple other colleagues are writing a commentary where we talk a little bit about this. We talk about the emotional labor involved with conducting research, especially in a stigmatized environment, especially qualitative research, power dynamics and things like that. And so again, I'll draw from what Hillary shared with me when talking with abortion patients. And so she conducts interviews with abortion patients themselves. This is not from the chart review. She says they don't just talk about actual abortion, they talk about fears, hopes, dreams. They talk about their relationships, violence, poverty, harm to loss of their existing children, drug use, homelessness, the list goes on. And so it's important to respect and value their sharing. And I feel as researchers, we have a duty to honor and sharing in our work. And so you can tell she's thinking about all of the emotional and intimate nature of the conversations. And we can use our research to honor that so long as we're doing it in this kind of respectful way. We've also in our commentary and in conversations, we've talked about how doing this type of work leads researchers to carry an emotional weight, and we're not trained as therapists, don't necessarily have the disposition to be a therapist, and yet there's still this emotional work that's going on. Another thing I'll share kind of related to this is another of our colleagues, also author on this commentary, is Dr. Tamika Odom. So she's a faculty member at UC Blue Ash. She's a Black woman, and she's leading a project about the experiences of Black women seeking abortion and contraception in Ohio, and in particular, the role that mistrust plays in this process. And so thinking about this from an intimacy framework, trust building, I wonder if a researcher having a similar background or experience or social identities as their participants allows this intimacy to grow more quickly in a way that leads to more effective research, but also, better, more positive relationships between participants and researchers. Let's see. Yeah, so I kind of said this at the beginning. I do think that intimacy, the idea of intimacy really captures why qualitative methods can be so challenging to undertake and teach and describe. It requires a lot of and quantitative research too, to some degree, requires a certain amount of introspection, self-reflection. What does it mean to be translating someone's experiences for scientific purposes? And yeah, like I said, I could tell during my graduate training that level of intimacy of doing the interview type work was not something that I could sustain across a whole career. So that's kind of how I've ended up where I did, but I really appreciate working with folks who do qualitative work. Okay, so that was quantitative versus qualitative. I'll turn a little bit to what makes abortion and abortion research unique. And yeah, I'll be curious. I think Jasmine has written a lot about pregnancy and abortion, so I'll be curious on your thoughts as well. So abortion and pregnancy are inherently related to the body. There's this inherent level of physicality involved, physical intimacy. Pregnancy comes from a sexual encounter, and so there's a certain amount of sexual intimacy involved with that. In our culture, sometimes people think they can touch a pregnant person's belly, or they have a stake in the healthy development of the fetus. And that has to do with these kind of crossings of intimacy between the pregnant person and other people. On top of the bodily intimacy, abortion is also stigmatized and politicized. And I'm going to quote some work from Dr. Kelly Ward, who's a faculty member at University of Wisconsin. And she talks about the social and moral taint of people who do abortion work. This is based on an ethnography she conducted in an abortion clinic. And so she writes about abortion work as both intimate and what's considered dirty work. And she says, those who work with physical, social, or moral taint are responsible for protecting society from contamination. And so she talks about it again in the context of people who are providing abortions, but I think it also can be true in a little bit for researchers as well. Thinking back to the qualitative and quantitative divide, those who are closer to the participant have a more intimate relationship with them and maybe are doing in this framework some of the dirtier work involved in an abortion research. Okay, and then another piece. Oh yeah, so another thought related to intimacy is when researchers and patients and providers, anyone goes to an abortion clinic, in Ohio and in other states where abortion is even more accessible, there are often protesters who are legally allowed to be kind of nearby the clinic, if not on the private property. And so as someone walks into the clinic, they can be forced to look at graphic images that aren't actually related to abortion, but are meant to elicit an emotional response. We've observed protesters will clock a patient or researcher's race and say things specifically targeted to what they perceive as their demographic. And in some ways, this too feels like a violation of one's intimacy. And I hadn't thought of that as an intimate violation prior to thinking about this panel, but I can see some overlaps there. And so, for example, our researchers would put headphones on or use a sound machine to kind of block out the noise as they were going into the clinic or in the chart room. Right, it's something that you might not have to do if you were conducting research on a different form of medical provision that wasn't as stigmatized. And then the politics of abortion is also interesting, gets at some complexities around intimacy. So some of the questions we think about: what is the role of the state in supporting the well-being of the pregnant person? What about the well-being of the fetus? What happens when those two are at odds? It's a very intimate decision. And the foundation of Roe v. Wade, which was the legal precedent that had been turned over in 2022 with Dobbs, it wasn't related to gender equality or healthcare access. Really, it was related to privacy. And the decision was made that the Supreme Court decision determined that if the decision to terminate a pregnancy was a private matter between the pregnant person and their doctor, and that kind of philosophically underlies the level of intimacy involved in pregnancy and abortion. And so some of the quantitative, qualitative stuff, applies across the board. But I feel in studying abortion, it does feel like the stakes are somewhat higher. That feels that much more important to respect the intimacy of research participants. The consequences feel a little bit more dire if any of these things were to be violated. And that brings me to my last point, just briefly talking about more recent concerns around data privacy. So collecting data on abortion in general is challenging. Like I said, because it's stigmatized, it can be, there's social desirability bias. If you're doing a survey, someone might not want to share that they've had an abortion. So we have all these different methods, and that's kind of been true across the board for as long as we've been studying abortion. What's newer now is the way that these electronic systems are all connected. And so, we've heard about how different EMR systems can talk to each other now, including across state lines. There's benefits to that, right? That providers can have maybe a bigger picture of what might be going on with the patient, but there's also concerns. If there is a breach, there's much more information that's leaked. There's the concern of a patient who goes out of state for an abortion. It's fully legal, but if it's in a chart that their maybe home provider sees, there may be some discomfort with that. There may be a intimate violation, right? Because that provider can now see what happened in another state and the decisions that the pregnant person made. And of course, there are implications for criminalization. We've seen in the news someone coming into an emergency room and then that information getting shared with law enforcement that they had an abortion, then getting criminalized for that, even if they weren't, so that information wasn't supposed to be shared, even if the charges were eventually dropped because what they had done or were doing wasn't actually illegal. All right, so those are the three main things I want to talk about: quantitative versus qualitative work, how abortion is unique, and then the more recent concerns around data privacy. But I'll pass it back to you, Dana. Thanks.
Thank you so much. Thank you both. I think that one thing that is really interesting that I'm hearing is, in some ways, some of these issues surrounding intimacy haven't exactly been overlooked. Like, at least, Mikaela, I mean, I love how you were bringing in the community and network of researchers and how you've been like having these discussions. But in some ways, like Jasmine, sort of thinking about the intimacy frame gives an orientation and like conceptual understanding of how to think about this and how to tease out something that is, I think, really difficult. So thank you both for sharing. So there's some really great questions already from the audience, and I have some preset questions. If you have questions, audience members, like please feel free to keep on asking them. The first question actually is a clarificatory question that I just want to give Jasmine an opportunity to respond to. And it's from the audience. And it's basically one attendee asked, is consent not required if the risk is low enough? If that was what you said, could you please clarify what is meant by this and in what context? I think this is really helpful both for thinking about the no more than minimal risk, but also thinking about chart reviews. So please help us figure out what the actual regulations say if possible.
Yeah, so at least with some cases of research, consent is not legally required when it is below this minimal risk standard, or when it's, not impractical in some way to get it. Um, because people are unconscious or you're looking through so many charts and but generally the thinking is uh, the risks to these patients from having their charts reviewed um, is not there's just not enough of a risk to them to make consent necessary. So certain kinds of other research, where you're observing people in some ways, sometimes you don't need consent. So legally, yes, you don't always need consent for research. You might think that that's not right morally, but I think at least some of these cases you might think it's more plausible. Maybe not where intimacy is involved, but cases where the observation does just seem too mild, the data is completely de-identified. Um, so I don't know. I hope that that's
Yeah, no,
sufficient.
that's really helpful. And in general, one of the things to just sort of think about is sometimes researchers can request waiver or modification of consent. Like you may have to ask consent after you sort of collect the data or the biospecimen. Especially this happens a lot in emergency situations where it's just not feasible to, and as you mentioned, Jasmine, like it's both not feasible for many of these patients who are unconscious, and also it might actually be ethically problematic to request consent given the underlying pain that they're experiencing. So, yeah, so this is, I mean, it's an interesting, in some ways, it's a somewhat wonky sort of place where people think about it. And one of the things that researchers and IRBs need to pay attention to is whether or not the potential harm or risks are more than what they would experience in normal life or in clinical practice, right? And so, again, this is sort of based on one of the things that you were mentioning, Jasmine, like it's really interesting to think about like intimacy harms if they're different from other types of harms. So maybe something, so given that sort of clarificatory question, maybe one sort of general conversation question that I wanted to sort of have us think about is, should risks of intimacy harm be considered like a special category? Or are they already, I mean, it seems like we're already worried about this or thinking about this. Are they all related to other sorts of vulnerabilities that we as researchers and as like regulators and are already paying attention to when it comes to how to conduct research ethically? So why don't we start with Jasmine and Mikaela if you want to also add.
So I think it is certainly related to categories we're already worried about. And so in particular, we're already called upon to think not only about physical harms, but psychological harms to participants. And so I think it's reasonable to consider um, this is sort of a species of psychological harm, these intimacy related harms. And I think also there's a lot of talk about, conceptions like dignity harms, which of course can be a little tricky to nail down exactly what that means. But I think it's plausible to think that um, intimate harms are dignity harms. In addition to psychological harms, at least sometimes, because to uh, not respect people's intimate boundaries, at least can sometimes be a way of not treating them as persons, because the way that getting to control our own intimate boundaries is so related to our getting to act as autonomous agents in the world. So I think it can be a really fundamental kind of disrespect. And so I think it's probably captured in part by both psychological harm and dignity harms.
And Mikaela, do you want to add to this, or is like intimacy harm or risk vulnerability to intimacy? Is it something above and beyond things that you've already been thinking about, or is it just a way to like really understand some of the concerns that you've already been sort of thinking about?
Yeah, I think it like gives name to some of the stuff that we've been thinking about in a helpful way, and the hope then is by naming it, we can be better about protecting against intimate violations. In the IRB, there's like a sub thing. If you're doing research on pregnant people, you have to do a separate kind of I don't even remember the details of the form, but there's a whole separate form around pregnant people. So in some ways it is built in, but I think the language of intimacy really provides a helpful way of talking about it.
Yes, because currently pregnant people are a protected class, according to the common
Yes,
law.
thank you. Protected class.
Some
That's
of
good.
these concerns related to more than minimal research are actually like really do affect what sort of research can be done when it comes to research on pregnant patients. Um, Great. So, okay, so that's sort of like a starting a general conversation. So let's now think about, I mean, some of the actual participants have already sort of tapped into this. And it's really interesting, Jasmine, how you're conceptualizing this because consent and privacy are really tightly sort of connected to what counts even as an intimacy violation. So, how should we think? So, Larissa Faustin asked, how do we navigate consent and changes in the law to not infringe on intimacy? And sort of one further question is like, how should we think about consent and intimacy? So, if people have already provided their informed consent, are there still any residual concerns related to intimacy harms that we need to be paying attention to? If so, in what way?
I could say a little bit here. So I certainly think that uh, consent is not just this sort of magic thing that when it occurs, now there's no risk for intimate harms. So you might think if it's the case that everything that happens was indeed consented to, then maybe there's no possibility of intimate violation. Uh, but that doesn't erase the possibility of other intimate harms. So I think this is where things like sensitivity come in, and especially because the way intimacy makes us vulnerable, I think psychologically vulnerable, um, can happen even when consent is obtained, when consent happens, and when even in cases where intimacy is desired, right? Um, Nonetheless, it can still touch on sensitive points for people, and so we have these risks of shame and stigma getting intensified. So I think we still have to think about all those things in our interactions as researchers. Um, and IRB members, uh, even when there is consent. And I guess I'll say also with this relationship with privacy, briefly. So I think privacy and intimacy can come apart, and there's lots of data that's private but not intimate. So, for instance, your social security number, I think that's private but not intimate, right? And in part because of the different sorts of harms that we're subject to. So I think when we're concerned about privacy harms, we're sort of worried about down the line consequences that could happen to people because of this information being revealed, right? So someone could steal your identity and this and that way financially harm you. Um, when we're thinking about abortion, there are legal consequences now that people have to be concerned about. And so I think those are sorts of privacy concerns, where I think that intimacy concerns really have to do with the psychological aspects of those harms.
Mhm.
So that's my take on how those conceptions can come apart. Though, of course, there's often both sorts of concerns in any given case that we have to pay attention to.
Great. And, sort of jumping into thinking about privacy, and maybe we'll start with Mikaela on this question. So, I mean, I'm wondering about how to respect participant bodies and stories in the way in which we share and publish our research. And you've touched on it a little bit, but if you can share a little bit, I mean, one way of thinking about protection is like de-identification, right? Is de-identification enough? But there are certain ways in which maybe we should be more sensitive, as Jasmine was mentioning, and be attentive to the possibility of intimacy risks as we share our findings. So, how should we navigate that as researchers, and what should we look out for?
Yeah, that's a really good question. So again, we can kind of talk the practical side of things like the IRB and legal protections and things like this. And so there's something called protected health information where I forget exactly how many and what combination of things counts as like once you have enough information about a patient, that can counts as PHI. And so then again, you have to take on these extra layers of data security. De-identification, yeah, basically means like if I'm looking at the data set, even if I have the person's race, education, age, I can't necessarily figure out who that specific person is. Even so, we're not publishing de-identified, we're not even publishing that level of data. We're, continuing to aggregate up and saying, okay, people who are under 20 tend to have these kinds of abortions and stuff like this. So yeah, that's all the kind of like very practical side of things. I think it was brought up earlier, this idea of like weighting the potential risks and potential benefits. And so I think one thing we can do is when we're sharing the stories and publishing the data, doing it in ways that do serve to give back to the participants or the communities that we're conducting the research in. So at Open, when we have a peer-reviewed journal article comes out, we try and do a lot of public-facing kind of media dissemination. When we're working with the clinics that we collect data at, we'll give them annual reports of their data, kind of a snapshot of what they've been doing. So trying to increase that potential benefit, even if we're not decreasing the potential risks. Had one other thought. Let me see if it comes back to me. De-identifying the data. Oh yeah, and I think another approach that I haven't engaged with, but another approach to conducting research is, you write up your findings and then you share them back with the participants and kind of make a dialogue. Is this what you meant when you said this? Does this represent your experience? So I think that's another approach. It gets really sticky when you try and think about like how do you stay objective and separate from the research, but I would argue, everything's a little bit subjective. So I think it's interesting to think through these different potential approaches. Or doing another way of doing is community-based or community-engaged research, where the community members themselves are involved in the development of the research question and the all the way through publication, writing the content.
Thank you. And Jasmine, I mean, yeah, how should we think about this more like from, a macro level when it comes to sort of publication of research findings?
Yeah, so I think this is a really interesting question. And one thing that I was thinking about during this is that it seems like there's quite often a focus on, de-identifying data. So who that person is not uh, discoverable by other people. But that there's this other sort of harm where it's not just that we have to worry about other people knowing who this person is, but also a person seeing themselves in the research, right? So I think that when we're worried about these kinds of psychological harms of intimacy and exposure in certain ways, we also want to be sensitive to what will it be like to, recognize yourself there, even if you know that no one else will recognize you, and that we want to be just attentive to those kinds of concerns too. And I think Mikaela's suggestion about this being related to the importance of sometimes, especially in certain sensitive or likely to be sensitive topics, running these stories by participants, and how they're presented, so they can be prepared to see how it's going to come out, and also feel as if they're comfortable with how they're being reflected in that story, insofar as that's possible.
Thank you. And another great question from the audience that is related to sort of the final question that I have, and is going back to IRBs, but I think in an interesting way. So the main overview question is just like, should IRBs be specifically concerned with risks of intimacy violations? And if so, in what way? And Jake Earl, who's in the audience, has asked this in, I think, a very specific way that I think is really helpful to think about, like the logistics of this. So, according to the common rule, minimal risk means that the probability and magnitude of harm or discomfort anticipated in the research are not greater in and of themselves than those ordinarily encountered in daily life or during the performance of routine physical or psychological examinations or tests, something that we sort of talked about before. It seems like the risks of intimacy-related harms or discomforts are inherent in daily life and in routine physical and psychological examinations. So how can researchers and IRBs determine whether a study uh, or its procedures introduce elevated intimacy related risks that go beyond those involved in daily life or routine physical and psychological examinations? I think that's a great question. And one thing sort of to like elaborate on it, one thing that I'm hearing from you, Jasmine, is that the key to vulnerability of intimacy is not to just like imagine a world where there's no intimacy anymore, right? Like that would not like do research with no intimacy would actually like undermine many of the like important research projects that we need. And also sometimes I think you mentioned at one point, people welcome intimacy or are open to be vulnerable to being intimate with their care providers. So yeah, so given that, like, what should IRBs do to think about intimacy in a way that is practicable?
It's a great question. So I think one thing that's particularly important here is that often a difference between at least certain the kinds of research we're thinking about, especially when we're thinking about waivers of consent compared to uh, everyday encounters and clinical care, is that we're imagining that those are generally going to be consented to, right? So even if there's the same level of touching, that actually touching without consent adds a different sort of psychological harm, subjects us to additional risk. And so I think that's that's helpful there. And of course, it's I think trickier when we're thinking about cases where there is indeed consent in both cases, and then it does seem like that could be more parallel. But then, of course, it's we're not thinking anymore about these cases of consent waivers. We're thinking about something else about when is it permissible to ask research participants to engage in something that is likely to have some intimate risks. And then I think that's actually giving us the right answer, which is, well, it is permissible to ask them to join in these studies. And so I think really the consent is just doing so much work there and helping us think through what the additional harms are and why it's exceeding the sort of minimal risk and the risks of daily life. Even though, of course, there are like issues with some kinds of medical care people receive, sometimes being iffy whether or not consent is fully there. That's an issue, but of course, I think we should be thinking about the cases where, I mean, there should be, right, consent in medical care
Mhm.
insofar as it's possible. Mhm.
And then the next question is actually for Mikaela, and I'm going to broaden it a little bit. It might be the last question that we have for today, but so the next question is about how how is abortion safer than carrying a pregnancy to term? I think that that is like an interesting and important question in itself. But also one thing that both of you mentioned is that pregnancy may actually and care for pregnancy may actually require more intimacy than abortion provision. And so maybe just those two questions. How is it safer? And also like, how is intimacy related to abortion practice and research and also pregnancy practice and research? So we'll start with you, Mikaela, and Jasmine, then you could go next.
Yeah, I can especially speak to the first part of the question. So the statistics that we usually use is looking at risk of pregnancy-related death. It's about 14 times higher for people who carry a pregnancy to term than for someone who has an abortion. So that's the statistic we often throw out. More recent research suggests it might be higher than that, even like 30 times more risky to carry a pregnancy to term than to have an abortion. Part of it is the duration for which you are pregnant. So pregnancy, it carries with it inherent risks. And if you're pregnant for 6 weeks, that's 6 weeks of those risks versus, 40 weeks if you're carrying a pregnancy to term. Um, so yeah, from a very like practical medical standpoint, that's what you mean when we say that it's safer.
And Jasmine or Michaela, do you want to sort of talk a little bit more about thinking about abortion versus pregnancy? And I mean, it doesn't have to be either or, there are different kinds of intimacies that are involved, but how can we think in a practical way about like intimacy and vulnerability to intimacy in these two very related contexts?
Jasmine, I would be interested to hear your take on this because I was quoting it, but I was quoting your stuff.
Yeah, sure. So there are many considerations with both. So I think the length of intimacy with medical professionals is generally more extended with pregnancy. Um, and I thought, Mikaela, you raised a really interesting point about sort of the role of if the stigma is playing in the case of abortion that could make it such that there are additional intimacies there because of because of the way it's stigmatized, such that patients might feel more self-conscious about the procedures. So I think that strikes me as a really important difference too. Um, the relationship with the public, I think, as pregnancy becomes more visible. This is something Mikaela mentioned too, can make it so I think at least an abortion at an early stage compared to abortion at a later stage or completing a pregnancy um, tends to bring you into more intimacy with the public, in part because they might feel more comfortable touching you, but also commenting on your life or observing your choices in certain ways that they normally wouldn't, right? So looking at what you're eating or you're drinking, that brings you into this intimacy with the public eye. Um, so I think that's an important one. And there's also, I think, interesting ways about how many pregnant persons are conceptualizing their relationship with the fetus and imagining themselves to be growing a relationship. That's that does important and interesting moral work there. Um, that could certainly be present also for some people who decide to get abortions for various reasons, but for other people who decide to get abortions, they won't have that sort of rich imagined relationship with the fetus. So they might not have that same sort of intimacy or feel like there's an intimate exposure and an intimate relationship being built there. So I think that's a really interesting sort of difference. Um, those are a few.
I think the other thing that struck me in your writing about it too was like the embodied intimacy of like once the fetus develops to a certain amount, you might feel it kicking, right? And that's it's like internal, it's a very physical type of intimacy for the pregnant person themselves.
Yeah.
Yeah.
Well, I we are out of time, and I want to just thank Jasmine and Michaela for talking with such like clarity and sensitivity about these issues. I feel like we got some real practical sort of recommendations about how to move forward and what to look out for, but also some real like conceptual um, like language to just think about these issues more. So I really appreciate that. And to the participants, thank you again for asking the excellent questions. We actually have our next care panel in 2 weeks, and it's part of the Love Data Week that OSU is participating in with the libraries. And we're going to be talking about the missingness of data and how to think about researchers' roles in sharing data. And I think that some of these issues that Mikaela is bringing up are definitely going to be echoed in that conversation as well. So thanks, everybody, and I hope you have a good day.
Thank you. Thank you for your questions.